Tell, I have Christine Hall, I have Kimberly Jolivet Williams, I have Betty Hovey. We may have some more pop-in guests, who knows? But we're excited to talk about the final rule. Now, I had some things I want to talk about today on the agenda, but I know everyone else probably has their own, yes, I want to talk about this. So I think for us in the business world, those that deal with providers and physician groups, before we get started today, I just wanted to shout out and say that compliance document that came out from the OIG, just before we get started. Who is super excited about that? What are your thoughts about it? How long have you been waiting for this? Anyone speak up?
Oh, I have been so waiting on this. I'm not going to lie. I knew that it was coming. I knew that the new guidance was coming out. I was so super excited because things have changed in the last 25 years. So it's nice to see that we've got some updated elements there, that we've gotten some more definition there, maybe in a language that we understand a little better, maybe not so legalese as it was before. So I'm really, really excited about that.
Yes, I definitely am excited too, being new in compliance and learning, and this being my new wheelhouse over these last couple of years. I've enjoyed it too. I was excited to see it. I got to get through all of it, but I love it.
Exactly. It's absolutely perfect. I think its new construction is much easier for our providers to actually swallow, right? I know many of the pieces parts are things that we have all seen in the industry over all this time, but in terms of the semantics, it's much easier for practices to digest. Despite this part one, it's about a 90-page document, but still it's broken up into sections. And I think it's much easier for organizations to read. Yeah, love it.
Yeah.
I know. I wish I would have had it last week.
Yeah.
What? We have so much reading. Last week was crazy, right? This final rule was 2,700 pages. I know.
Oh my gosh.
I'm reading it all, but yeah, lots of new changes for sure. Per every fall, as all of us in this space know, every single autumn we are bombarded with the new changes. So yeah.
Yes. So
what do you mean, Sonal?
I wanted
the
to
only
talk
thing that we can count on is change.
I know, right?
Oh yeah, exactly.
Yes.
And we have to get on board, right?
We do. We have to get on board. Yes.
It's just job security for us ladies.
Yes.
Yeah.
Yes. One of my old physicians used to say that, job security.
We ain't going nowhere, girls, at least for right now. So let's dig in. I think the first thing I want to talk about, and I think, they had a lot of good intentions when they created the G2211. I know we love this new code, right? And I thought that there's a lot of feedback. There's a lot of things going out there, but on a positive note, I read the comments, I read the responses, and I definitely see the behind the scenes, what their thoughts were. And I know that there's effects there, and they did address some things they're concerned about, that we're concerned about. So let's start with you, Betty. What are your thoughts on G2211?
Well, I think reading the comments and what CMS said about it, they first thought it was going to be used all the time. Then when people freaked out because of what they might do to the conversion factor, then they came back and said, well, maybe not all the time. But if you read through the examples that they put in there, I think they're going to try to use it every visit. It is my thing. But the thing that I think is going to be the most difficult, at least from my perspective and from the education of the physicians and APP's perspective, is going to be that they want to look for that link of the established relationship, because somebody put a couple of examples that they thought might fit, and CMS's comment was, those are okay examples, but they don't indicate the relationship. So my question is, how are you going to show that relationship? Like what kind of documentation, what ways are we going to have to kind of put out there for documentation purposes to indicate that there is that relationship between them? Because they gave some example, CMS did, of like a sinus infection or sinus congestion, and said, well, it still could be used for that because you've got this relationship with the patient for these other conditions. I'm like, okay, well, how are you going to show that?
I think the key is
Agreed.
showing it. I mean, you have to have good documentation. Christine, what do you think? I mean, I know there's been talk about the, of course, budget neutrality issue. So what are your thoughts there?
I was about to go into that. Again, knowing that for those of you that don't understand what budget neutrality is. So Medicare says, listen, we expect that we're probably going to have to add about $20 million a year to the Medicare program. So if we exceed $20 million, then you guys have to work it out. So we might take some money from one service to compensate for another service that maybe has an increased RVU, or again, it simply says that Medicare is not going to receive more than $20 million this year. If you need more money, work it out amongst all the other services that you have. We're not giving you more than $20 million. So budget neutrality, again, just means that we're going to have to take to give. So now we have a new code, and it's not going to be a whole lot. It's not going to reimburse at a whole lot. I understand that it's going to be in the $20 range. But if every primary care doctor is reporting this on every visit, can you possibly imagine that we're going to $20 million sounds like a lot, but it's really not. And how upsetting would it be if we start taking it from other services that are needed, that we're decreasing the reimbursement for those services that probably aren't valued at the way they should be valued anyway. So it's really important that us as compliance officers, as compliance individuals, that we're talking with our providers and saying, yeah, look, I know that $20 means a lot to you, but is it really appropriate for this patient? It's not going to be appropriate when you're using a modifier 25. It's not going to be appropriate when you're doing another service today. And then, like Betty was saying, I'm not so sure that those acute visits are appropriate for this code. So I'm going to hand it back over to you guys, but that's kind of where my area of concern is that we're going to start losing money in other areas because this may be overutilized.
Yeah, it's that robbing Peter to pay Paul thing.
Exactly. Yes.
Yeah, exactly. You know, when we first saw the code, you know, in the HCPCS book in a couple of years ago, right? So it was identified, we were aware of it, we knew we couldn't actually use it because there was no reimbursement attached to it, right? The reimbursement is finally going to be attached as of January 1. So, you know, as you read through the like 17 pages that are in that PDF file, you know, a lot of time was spent on the comments that came in from the people, right? So I do think it's a rather wonderful, unique opportunity. But again, we have to be cautious and make sure that our primary care physicians are actually documenting things appropriately, especially based on CMS's new stressing point that it is going to be that relationship between the provider and the patient that has to be captured, right? So I too gave pause to that example that CMS provided for that acute condition of the sinus, right? They tried to provide facts as to how it could be appropriate based on their very long-winded definition of what 2211 is, right? Trying to break it down into two parts, why it's appropriate for part one and part two, et cetera. So you really do need to, if this type of a service is applicable to your service line, to your practice, to your healthcare system, take the time to read those 17 pages and actually understand, take it to your legal team and try to understand how this might be compliantly utilized at your practices. So yeah, I definitely love the code, but yes, we have to be very cautious with who is going to be coding for it, billing it out, et cetera. Because yeah.
And I think that's true with any code we have, you know, there's always something with it. You have to learn how to use it. Anytime it's a new code, we get scared or use it. We just have to get comfortable with it.
Yep, and
And
that's exactly what I was going to say. We have to make sure that even when we're educating and we're given the information, that we make sure we're confident in what we're telling them, because things like those 17 pages, even for all of us that are seasoned, right, it causes us pause. So when you think about the novice or the physician who doesn't see it all the time, they can be easily confused. I mean, just the language alone confuses us. And so I too, I agree with any new code, we welcome them, but we do have to make sure we're confident in what we're disseminating and educating, especially for compliance, to make sure, and especially for what Christine said, and Betty, it's robbing Peter to pay Paul. Do you really want to invest in robbing Peter for this? Is it worth it? Or do you want to get your services for the things that may be more relevant to that patient management of their treatment?
Exactly.
And don't forget, if it goes nuts with usage, then be prepared for a lot of auditing on that code to come right after then too. So if you
We
don't
love
have
audits,
that
right?
portion in,
I know, it's almost like a little teaser, right?
I don't know about the rest of you, but I'm getting, I mean, my phone is literally ringing off the hook regarding some of the audits for services that were rendered during COVID.
yep,
So remember, you're not going to see an audit tomorrow if you start, we're not going to see it in the first quarter of 24. We're probably going to see it in 25 or 26 audits regarding G2211. Just like right now, we're seeing audits for services that were rendered in 2020.
Oh, yes.
And
2021.
we've slept since then. A lot of us don't even remember. And 2020 was crazy. The rules were changing every 5 minutes, and payers are clawing back money. They're telling providers, listen, because you didn't know, that's not our problem.
Oh, yes.
So think about that.
It was published.
Not an excuse, right? Ignorance is not an excuse. That's what they tell us.
Right. So think, you may not have a problem in 24 reporting these, and you might get paid, and it might be a great year. But when you've got overpayments in 25 and 26 that you've got to repay because it wasn't used appropriately, it doesn't matter whether it hurts today or tomorrow. It hurts.
Yes.
Yeah. And in one lump sum.
Yes.
So let's jump into another area so we can kind of cover more of these topics. Great stuff there. And I do want to shout out to Miss Terry Fletcher, the Codecast podcast, because she did cover this, and it's a great episode. So just want to shout out to listen to that podcast. So let's move along to telehealth. A lot to unpack there. I know kind of Christine's eyes are like bulging because she's like so excited to talk about telehealth, but for myself personally, I don't work in telehealth every day. It's not something I really touch. I'm more on the surgery side, although I do see some of it. But I know a lot of you ladies deal with it. I noticed the comments, and I noticed what I noticed personally was just that there were a lot of comments about, hey, we should make this permanent, or we should make this service a category 1 or 2. And then CMS had their comments. And I do agree, with others I've heard. I think we're just trying to grasp at straws here. We're trying to stay in telehealth, and we have to kind of draw back. COVID's still around, just like any other disease, but it doesn't mean that we need telehealth for everything anymore. So I'm a little worried about the comments. What do you think?
We have to make sure it's not just for convenience, right?
Exactly.
I'll jump in.
Yeah. Yes.
So has anybody taken a look at the new instructions that were added to CPT? So CPT, in the very beginning of the book, I go through the book every year when I get it, and I look for the green items in there. CPT did an amazing job in the introduction section of outlining when you should use telehealth, when you shouldn't use telehealth. Just because, and again, this is going to be my new motto for 24, just because it can be paid doesn't necessarily mean that it's appropriate for your patient today, right? So I would say that a lot of times when CMS reviews the final rule, they make comments to agree with what CPT has published. So we'll talk about that a little bit later when we get into split shared services. So it's important to know that, even though we're talking about the final rule, a lot of times the final rule will say, hey guys, check out CPT because we agree with AMA. We agree with what they said. And guidance on telehealth couldn't have been said better. I know that Terry Fletcher and I were both talking about it, and we were like fangirling over the AMA's guidance for telehealth, especially since the final rule is going to extend a lot of the waived requirements for payment through 2024. So the two pairs, CPT and the final rule, was a really nice mesh.
I agree. What do you think, Sonal? What are your thoughts on that, on telehealth?
Yeah. I mean, we've been waiting for the new guidance, right? We've been talking in this space for quite some time about the relaxation. What is going to happen, right? What's going to tighten up? What's going to stay relaxed, right? When I read, there was one item that gives me pause, and it might just be me, but I thought we could talk about the direct supervision.
Yes, I was on my list. Go right ahead.
The audio, video, that's still going to extend for another year. So what are our thoughts there? I never quite understood how that would actually work for specific service lines, that direct supervision could be provided via the phone, through the audio video capability when it was necessary. I didn't like it when it was first issued, and now it's being extended. So that's just my opinion. And a lot of the commenters really were quite happy that it was going to be staying on, and they provided their examples of why they thought it was a great thing. But in my opinion, I was like, wow, I'm just surprised that it's still going to continue.
Yeah. And I think a lot of it too, when you read some of the comments and their responses, they're really trying with a lot of these things that they put in the telehealth section to say, a lot of these other services that we already said we're going to extend through 2024. We're just trying to keep it simple. And then I'm assuming, I'm pretty confident when we get the 25 final rule, when they start kind of moving away, I'm hopeful that we'll see some updates and some clarifications there. But I do agree. Yeah. Is it just for convenience? Are we excited because of that? From a provider standpoint, I know they have a different take than we do on what they like to see. But it is what it is. I think we just need to focus. Before COVID, you went to the doctor, supervision was there. There's a need and there's not a need. What's really appropriate?
Yeah,
Betty, anything you want to say?
For me, it's the immediately available thing. Yes. How can you be immediately available if you're, 30 miles across town somewhere?
Exactly.
Being on the audio video, okay, but if you actually need to do something, you've got an issue.
That's right. Yeah, that could be a risk for sure.
I'm with Sonal I just didn't get it. I did not get the whole, that's okay. And then when I saw they were extending it, I was like, oh, you gotta be kidding me. But of course, people love it because a lot of people are used to that. I can be anywhere and I can, and just like with trying to get people to go back into an office or trying to get people, I think they're just kind of, the longer they allow it, the longer it's going to go on. So, I really would have liked to have seen that stopped for this coming year. I was kind of surprised that they extended it too. I don't think it's a good idea personally.
Yeah. And I do think it's
we
more
go back to that state, guys. Yeah, exactly.
Yeah.
Convenience.
Yeah, they're trying to do it more for
you
convenience.
can doesn't mean you should, right?
That's right. Right. Yeah.
Exactly.
You do have to weigh your risks, right? What is the liability if you do this way?
Well, and we have to remember that, Kimberly, you hit it on the head. We have guidance that is general supervision, so someone can act within their scope under general supervision. Direct supervision, we have to think about that. That's our medical assistants. That's our LPNs. That's our phlebotomists. Imagine if a patient comes in for a blood draw that requires direct supervision, and maybe the phlebotomist doesn't understand that the patient is on anticoagulants or they're hemophiliac, and they start to bleed in the office. Direct supervision means that the provider is immediately available to give that guidance, not call 911. That's general guidance, right? So to say, oh my gosh, let's go get some factor, whatever, let's do this or that, or that requires that physician to be on site and available to assist. So again, think about that. We do have general guidance and those services that are under general guidance, but direct guidance, direct supervision, that's because that procedure has been deemed something that if it goes wrong, we need the doctor at arm's length
immediately
to come in and save the day.
That's
right.
right. They need to be immediately able to step in and control 100%. The situation. Yes. Yes.
And from the auditing perspective, think about that. Let's say the payor is auditing those records and they've also pulled the schedules for the physician.
Yes.
And guess what? One wasn't in the office. And so they say, I looked at this note. It doesn't meet incident 2, or it doesn't meet direct supervision. And they say, oh, well, they were immediate. How are you going to prove that? Again, so in those notes, are they documenting that Dr. Smith was immediately available via audio, video? Are you seeing that in all your notes? I'm not.
No.
Exactly. Yeah. Well, I think there's a lot to unpack. I encourage everyone to really dig in and call your local consultant, call your favorite consultant on this, because you need someone in your corner for 2024. It's not going to get any easier. You got to have somebody, any of us, especially with telehealth, I have my people, Betty, Christine, Terry, Sanal. If you know telehealth, these ladies are great. I kind of step away. I love it, but I get my information from these ladies because I will say, I'm the first to say I stick on the surgery side, and that's where I like to live. And
I think we've all said it. Not one of us is an expert in everything. However, together, collaboratively, we know everything. So we want you to continue.
We're an army, guys.
Surgery. Right. We want you to continue to have your area of expertise so that we can collaborate together and be successful for our clients, for physicians, for the healthcare industry.
I love it.
Yes. And ladies and everyone, these are my ladies that are on my advisory panel at Healthcare Inspired. So at any given moment, if I have someone that says, hey, I need this, I know how to go. And so we have a great team here to send you the right way. Now let's talk about split shared just for a few minutes. I want to cover as many things as I can in our short amount of time today. I was pleased with the definition in CPT. I thought it was great. And I was very excited to see CMS kind of sliding over a little bit, saying, okay, this is what we think. So what are your thoughts on that, Betty?
Yeah, I'm glad that they finally made it match the way we're doing CPT, that we're doing E&M now, because that was a question that constantly came up. Well, if it's the 3 key components and you don't have the big to-do check boxes for the 3 key components anymore, how do you choose if they did the complete history, if there's really only what's medically appropriate now? I was actually on a call from, I think it was Novitas. One of the Macs was giving a presentation on E&M and asked that question, and they said, well, all 3 key components are still necessary. So whatever would have been, so they gave that long-winded around that didn't make sense. So I was like, yeah, that's going to be a hard thing to prove. So now that they were saying now it's with MDM or time, then you can go, okay, now we can deal with that. So I was really, really glad that they switched over their verbiage.
Yes, because before they made it where I know for me, it was recommended to do an internal policy, right, in order to figure out how to handle it. Because especially when you deal with a lot of multi-practices and multi-specialties, you can't have one doing it one way and another doing it another way. So we had to develop an internal policy that said it had to require that they do MDM. Otherwise, it was just too much for the team to know what to do and how to move forward.
Well, I do want to address there is an elephant in the room. because some of the wording,
let's talk about it.
okay, so there's some of the wording that CPT came out with. I know that Terry and I, we went over this a couple of times between us because there was just a little bit that we weren't 100% happy with. And we thought to ourselves, with the amount of experience we've had with providers, this ambiguous wording could be taken advantage of. So there it says here that that for the purpose of reporting E&M services within the context of the team-based care, performance of a substantive part of MDM requires that the physician or other healthcare professional make or approve the management plan for the number and the complexity of problems addressed. And it goes on. And we had a fear that term, or approved, may be misunderstood. But if you read the next sentence, please read the next sentence. By doing so,
read all the sentences.
Has performed 2 of the 3 elements used in MDM. So it's saying that even though there's that little word in there that says approve, but by approving it, you are saying that you've actually done 2 of the 3.
That's right.
So remember that. Don't just cherry pick any of these guidances for the words that you like. Keep going to see if that is expanded upon and there's a requirement that's outlined.
Yes, Terry talked about it on her podcast too. If people listen in this morning, I actually listened to it this morning, and she definitely pointed it out, because
just
we do
today.
speed read. Yeah, we speed read, right? And we pick up the words that we think, or even not have the level of knowledge and understanding to know, okay, this goes together. You can't just stop at one sentence and take one part of it. I even have to educate that when I'm talking to, colleagues and providers, because they'll see that one little sentence and then they'll run with it. So.
And I think, Christine, that point too, when you said the approved thing, I think people might tie into that, like with the PATH guidelines, and, say, well, for PATH, I can say, I saw the patient with the resident and I approve, and you're good. So if they trying to equate that the same way, it's not going to work.
And we need to keep in mind,
audience. Go ahead, Chanel. Go ahead.
I was just trying to say that, and we need to keep in mind that split shared is only for the facility. I don't know how many times we have to keep saying it.
Yes, thank you. For Medicare, yes.
The facility side. And please don't forget to append that modifier FS, F as in Frank, S as in Sam, to your split shared services, because CMS needs to keep track of what is going on and who's doing what. So
and if we're not using split shared, then why are we talking about split shared? So you have to put the modifier on there so CMS knows we love split shared. We want to keep split shared. If not, if we don't show we use it, we lose it.
Yep.
That's right.
Yep. Yeah, and she hit that on her podcast as well.
Track us. They always track it,
It is required now. It's not an option anymore. You have to put it on there.
Exactly. So we have a question here from our audience. Do the 2 elements have to be problems and risk? I think overall we're looking at the way the verbiage is. It doesn't actually say specifically. Obviously, we're going to use MDM. What are your take on this? I guess, Betty, what do you think?
Do the 2 elements have to be problems and risk? The verbiage.
So we're using MDM, right? Like we can choose.
The only thing they talk about specifically is it has to be one of the 3 components. And if the component is the amount of data and complexity reviewed, that person had to actually review it. If it's independent historian, they had to actually say what it was that they did in data to capture that data component there. So again, CMS defers to CPT. CPT does lay that out, all 3 components.
They do.
But if you are going to use data, you personally had to do the data part of it, right?
And document that.
Correct. Yeah. And document it. Yes.
And I want to highlight too, in my audits, I just saw a huge amount of audits where there was a lot of split share going on in the facility. And And I'm looking at it, I'm like, I'm not seeing clearly even just now before 424, I'm still not seeing the clearness of it. I think there's just a lot of confusion, and maybe they're not getting the right education on what they need to document. I think it's just a matter of, hey, this exists, this is how we do it, but no one's actually stopping to educate the physicians on what needs documented. And yes, I'm a big EMR person. I love EMRs. I've used probably all of them that exist. A lot of them I've used, and I've seen how they work. And there's some issues with how they're set up and how they're, I guess, someone showing the providers how to use it to their advantage, optimizing it, as you could say. So I think that EMRs have a lot to do with it.
Yes, like my shameless plug, but Leslie Bowles is going to cover that this weekend.
Yes, she is.
Coding colloquium, so they can.
Yes, she does a great job on that. She did it for our conference this past year for ortho, and it's a great session.
Yes, she definitely does a great job sharing on that, and I love it. And all of you wonderful ladies will be there sharing as well.
Exactly. We're so excited this week to have that launch. It's finally almost here. I just can't wait to dig in and listen to everyone. I'm super excited. Well, and then I know there's a lot to unpack, and we have a couple minutes left. I just wanted we can't talk about this topic like in entirety, because I feel like it was covered over maybe 100 pages. Just this shared savings thing. And so I wanted to encourage everyone to read what you can, but is there anyone that wants to give their bullet points or highlights on what they think is impactful about the shared savings program?
I'll jump in. We're talking that MIPS is moving into a MIPS value-based reporting program. So
exactly.
We've got some new guidance that's talking to us about our MIPS program. We've still got a lot of encouragement for providers who maybe are interested in joining ACOs and reporting the APM side of shared savings. And a lot of the guidance that comes from that. It is a laborious type of thing. We're always trying to make sure we're closing those gaps for our MIPS and so that we are receiving that positive reimbursement. Don't forget that the sequestration is coming back into play.
Yes.
We also have the PayGo. That is also coming into play. They talk about that also. So we need to be prepared of how those shared savings programs, either penalties, I don't like to say the word penalty, but the sequestrations, the PayGo, how that's going to affect us overall. Those of you that are in administration and you're looking at your budgets, certainly you need to consider that when you're talking to your providers and how that's going to affect the overall organization. Again, you can call any of us. We'll be happy to help you in that respect, making sure that you are participating in a positive way with the shared savings program and that you're not finding yourself below that 75% mark and having monies taken away from you.
Yes, and there were specific services they mentioned. They talked about the beneficiary assignment methodology and all that stuff. And there's a lot of benefits and maybe some drawbacks to some organizations, to some specialties. They don't maybe understand how it affects them. So yes, call a consultant, so you can at least understand for your service line or for what you do, how it affects you and overall how it affects, of course, your budget. One last thing, I know Betty had mentioned it, and I think it's an exciting thing to talk about, was the SDOH risk assessment. One last thing I wanted to bring up. There was definitely a new code mentioned. I believe it was GO136. Let me make sure I have that right. I have it in my notes here. Yes, GO136. So this was added, of course, as an element during the AWV. So I think it's a really great thing to think about. I have been shouting from the rooftops, all of us at the risk adjustment, Christine, we've been talking about social determinants of health for a long, long time. And providers are, it's so much to have to dissect all this data, ask these questions. And so now we have some way, right, to at least get in there. What are your thoughts on it, Betty? What are you excited about?
Oh, well, I think it's something that we might see. My concern with it and it has been since SDOH came out as a thing, is that I have had and heard from some clients that are hesitant to do something like this because they don't want to deal with it when they get a response from a patient. Well, no,
Right.
I mean, because then it makes I've had the practice say, well, then we're responsible. Then if the patient tells us that they're homeless or they're, don't have the job and they're living out of it, then we then have to spend time to get social services and so I think they want to help people and it's a good thing, but I think they have to think it through in saying, okay, if a patient says that, we do this risk assessment and we see they have all these needs, then what do? Just say, oh, well, you can go call some people and we'll deal with your other issue right now. And it just kind of dies. Then who's responsible? So when you do these things, you have to have the backup for it. Like, okay, if somebody says this, then what? And then just make sure that you get them attached to the right things at that point. So in looking at it, CMS made a comment that they said they don't think it's going to be used that much. They don't think it's going to be reported that often. And I think the reason why it might not be is because of that. Okay, we did this. Now what do we have to do about it? Kind of thing. So I think the practices really need to kind of think that part of it through, not the actual assessment, but what do we do when we take the assessment and there's some positive things on there.
Yeah, like what are those next steps, right? Definitely have those next steps in place to make sure, because it is concerning, right? They do have to be concerned about the liability, especially with some of these conditions. If you have a patient that's on insulin for diabetes and they're homeless and they don't get their medication and they shared that, what are the ramifications of that kind of a care and treatment? So I do think the next steps, like I said, sometimes we just have to do our own internal policy procedure buffer. Okay, if we get this reported, then this is our next way to proceed. I think that's a great way.
But let's think about it from the other side of the coin as well. I know that a lot of my practices, when a patient says, I can't afford my insulin, that they get on the phone and they start calling and and this is going to be a great way to capture reimbursement for that time that we are following through. So it has its pros and cons. Again, I do worry with Betty and Kimberly on let's report it because we get paid for it. I think that's going to be a huge mistake, folks. But when you really do have those people in the office that are going above and beyond, calling Meals on Wheels, helping to get that set up for the patient because they cannot go to the grocery store anymore. They don't understand Instacart. I love Instacart, but they don't understand.
I love Instacart.
They don't even have a computer and Wi-Fi to get to use Instacart, right?
So it's going to have its pros and cons, but I agree. I think a policy in the office that says if we report this, then we must be doing XYZ services and educate your staff on that policy. So that they know that if they're doing that, they're on the phone getting that medication, that's part of that social determinant of health. So pros and cons.
Yeah, exactly. Well, no, I think it's great. I'm all about data collection. I love data. And I think that from my perspective, my brain is thinking on that level, because I always do, is the data we're collecting is important to help provide certain services. But again, thinking about all the comments here today, we do have to consider the implications. You don't just throw it against the wall and just see what sticks. You have to understand the implications. So, your parents always said to think this out, make sure your decisions, you think about what could happen. You don't just do it and hope for the best. You have to have a plan, which is why we have a compliance program, which is why we have policies in place. We've thought out every scenario. And if this happens, we'll do this. If this happens, we're going to do this. So it's just
follow Betty, because on Friday, she's going to tell you where other people have gone wrong. And you don't want to be part of her Friday fraudsters.
Yes.
But that's a great, I love it, Betty. I always look.
No, you do not.
you don't know what other people have been struggling with, and then sometimes that resonates, and you're like, oh my gosh, we're reporting that in our office too. And look, these guys got in trouble. We need to get on compliance. Are we doing this right?
Yeah. Or if nothing else, they make you aware to go look, right?
Yeah.
You need to go and look. Because
Yes.
I know we say all the time, we think things are going the way we think they're going, but we're really not sure, right? Until we go and look. Things always go better when we're watching. So we should be checking.
Exactly.
Because if you're not watching,
And,
somebody else is going to be watching, and you don't want them asking for the stuff first.
Right? Keep around your own front door.
Exactly. Well, ladies, it's been fun. I think we've covered a lot. You know, we could talk all day about this. I mean, like this 2,000 page document, but we're just going to encourage you. We posted the link, of course, in the comments on LinkedIn, and of course, it's out there all over. You can read it, you know, in your leisure. You have time to just sit there and read this 2,000 page document. But there's a lot of information out there. What's in it? Yeah.
Sonal, Kimberly, myself, Betty, you. And we can help them, even if they just need help with a certain section. Christine, tell me about telehealth. Betty, tell me about SDOH. Sonal, I need you to tell me about the G2211 code and how can I use that in my office. So it doesn't necessarily mean that you've got to book a day with us. You could just book some time to discuss this, and how can we help you get that implemented in your practice properly?
Exactly. There's a section for almost everyone, and we didn't need touch on behavioral health. We didn't touch on some of the other things, the therapy services. One of the things I will say is if you have that in your practice, or you work for FCQH, I always butcher that acronym. You know what I'm talking about. There's stuff for them. And, you know, I don't do that. I'm not in that world, but, you know, there are people who are in that world. So they can help you.
E&M time changes. We had some E&M changes again this year regarding reporting additional services, where a few years ago, if you saw them in the office and they went to the ED, only one doc got paid. That's not true anymore, right?
Yeah. Exactly. There's a lot of things to unpack. So we covered the things that we thought were interesting that, you know, we're watching, but there's so much in there about certain procedure codes that were revalued or asked to be revalued. There's a lot of nuggets you can take from the comments, even the people's requests for things, how people are thinking, right? What their thought process is, because it may be your thought process. And you're like, oh, I want to know why they said it this way. Then CMS comes back and says, here's our response. So now you can start thinking how they're thinking, where they're coming from. And a lot of people have comments they don't submit. They have thoughts and they don't submit them. And they don't end up part of the thought process of CMS. So think about how you next year get involved and make your thoughts known to people out there. So thank you, ladies. Any final thoughts before we jump off here?
Hey, I just say be dedicated, be devoted. You know, even me, I am not one to sit around and read 2,700 pages, you all. They would tell you I complain about it every year. Take it in small chunks, you know, take it in small time frames and do your due diligence. It's our onus to make sure that at least what we're sharing, we're confident and we can defend and we know why we're saying what we're saying. So
exactly.
That's my only symbolism.
What I tell people is look through the beginning where they list everything out. You know, E&M is section 3G, and this is you know, so look for your sections because all 2,700 plus pages probably don't apply to every single practice, right? So just look through that table at the beginning and write down the sections that apply to you. Look at the stuff that applies to you, and you know, then it's more manageable because once again, you're not going through the whole thing, and then you can read all the extra stuff, you know, as time permits.
And I didn't even touch on drugs, guys. There's a lot of stuff on drugs. If you're in that world, oh my goodness, I read on and on and on and on. It was a lot of great stuff. But again, there's other consultants out there like Mr. Jordan Johnson, one of my buddies, that can give you all that information about the drug part. But thank you all for joining. And I want to remind everyone to watch for information on the colloquium that's coming up. Yay. Please listen to Friday Fraudsters on LinkedIn. We have podcasts with Christine Hall is on, I think it's every Monday, right? With Sean Weiss and Terry and all that group. And she has her own podcast. What's your podcast? To tell everyone, Christine, what is your podcast
Coding
called?
with Christine Hall.
Yeah, it's got her name in it, guys. It's not hard to find. And then Sonal Patel, Paint the Medical Picture, one of my favorites. Sonal and I started our podcast journey together around the same time, and it's still going. We're both still podcasting, and mine is called Healthcare Inspired. So check it out. There's lots of great podcasts out there. Codecast, The Compliance Guy. Shout outs to all my favorites. So stay informed. Remember, if it's published, there's no excuse you didn't know. So get all the information you can. So thank you, everyone. Have a great Tuesday, and we'll catch you next time. We'll see you on our next live. Bye-bye.
Yeah.
Thanks so much.
Bye.
Bye.
Have a thriving